Good afternoon, everybody. We are going to start the joint session of the Israeli cardiac surgeon and the South African cardiac surgeon with me, Professor Zila from Cape Town. I think it's the second year that we are doing this session, and we have already one in South Africa. I hope next week we have another one in South Africa. I think it's very important for both of us. I want to thank the rabbi that he is the head behind this idea, and now it became reality, and I hope it will become a tradition. And so I hope we have a nice afternoon, please.
So I have the pleasure to announce the first speaker who presents joint work from Hadassah and from Zurich on novel total aortic arch endograft midterm results with the nexus graft.
Thank you, Professor Zila, for the team. Would you scroll down? Just not here. Okay, these are my disclosures. As you all were aware, there are different open and hybrid options to treat aortic arch and ascending aortic, proximal aortic pathologies, both open surgery, endovascular, and hybrid. However, none of them are approved endovascular device for off-the-shelf interventions. There are other methods such as periscopes, snorkels, and chimneys, but all are kind of improvisations and all are outside the IFU, and none of them is approved. Since the open surgical approach is associated with high surgical risk, most of the patients remain untreated because of the high risk, and obviously there is no off-shelf device available up to date. There are specific challenges associated with the endovascular solution for the aortic arch. Among them are anatomic, the curvature. This is an arch, so it's 180 degrees of curvature. Anatomic variability between the patients, the branch proximity. Obviously, we want to maintain flow to the upper part of the body. We want to land in the ascending zone 0, which is the most problematic landing zone in the aorta. There is motion associated both with heart cycle and breathing, as well as upper body movements, and the hemodynamics. This is the highest cardiac output and high pulsatile flow. So in this process of R&D to develop an endovascular approach, we went by first we defined the needs and the challenges, as you saw before. And we wanted, by definition, an off-shelf device to be suitable for at least 80% of the population. And we wanted also to be able to provide the operator an option to increase the confidence prior to the procedure. Since it's a complex, 3D anatomy is very complicated, we wanted to develop a method to make it easier and more convenient. So from the start, we knew that it's not going to be the standard concept of tubular graft plus branches, fenestration, etc., but rather developed a different concept, which is the two modules. One is the main module that is deployed from the innominate across the arch with a fenestration to the ascending, with an overlap to the descending. And second, it's going to be deployed the oriented ascending module, which is curved, as you can see. So this is the device. There are two options, two configurations, one with the open fenestration to the left common carotid, but currently we are not using this configuration, only single branch to the innominate, plus supraortic vessel preparation with either bypass or by periscope from the descending to the left subclavian. And this is the graft as implanted in a human being. And this is how we make the procedure. We start with a through-and-through wire, brachiofemoral through-and-through wire. We bring up the main module. We fix the orientation with this marker and start deployment. This is a self-expandable device from the innominate. This is the overlap and to the descending. As you can see, you have flow, maintained flow to the brain throughout the procedure. Second stage, we bring up the ascending module that is deployed with an overlap with the main module. Rapid pacing, deployment, and completion with ballooning, and that's it. That's how the device is deployed. As we said, there are specific challenges for every patient, so we started by printing the specific anatomy, and we're doing patient-specific rehearsal for each and every patient. We take the CT scan, we print the aorta, and then we connect it to a flow simulator, and we deploy the device one-to-one in the cath lab. And this is, for example, a recent patient that we made a training. This was an extension in the descending. You can see the main module deployed from the innominate. You have a diagnostic catheter here to make sure that you're not occluding the right common carotid. So this is really one-to-one rehearsal. This we open the overlap with the ascending. Take out the delivery system. Bring up the ascending module over the same wire, which is looped in the LV. Confirm orientation, rapid pacing, deployment. And it's amazing how much predictable the true procedure comes after you do the rehearsal and you know all the pitfalls and all the small details that you need to take care of during the procedure in each and every patient. This is kissing balloons and completion angiography at the end of the procedure. So these are the candidates that we had. We have more than 70 candidates so far, and we have models for all of them, and we've done the procedure on all of them. And you can see how similar is the reality to the simulation. So up to date, we have implanted the device in actually 31 patients. The last one was done last Friday in Rome. These are the patient characteristics. As you can see, half of them were aneurysms, and half of them were dissection, either pre-treated type A or type B. All patients were considered high surgical risk or prohibitive for open surgery. We had 100% of technical success, and patency of the nexus for last follow-up was full. One patient occluded the left subclavian to left common carotid bypass, and we had one type 1A endoleak from a chimney going to the innominate. This was a complicated patient, and 12% of type 1B endoleaks from the periscope, from the gutters of the periscope to the left subclavian. No type 3 endoleaks. And one late conversion to surgery. This was a dissection patient that maintained flow through the false lumen back to the ascending despite covering the proximal entry tier. So after a few months, he underwent surgery. Mortality rate, in 30-day mortality was 8%, another 4% late mortality. 3 patients, 12% strokes, all minor, all recovered completely, no spinal cord ischemia. And one case, important LV perforation from the wire, from the tip of the ascending module. And 20% reintervention due to try to occlude the endoleaks from the gutters. This is one patient with a periscope to the left subclavian. You can see the CT scan, post-op 1 month and 12 months. No, actually, no deformation and no migration of the device. Okay, almost done. And this is how it looks with the CT angiography. So to summarize, we have an innovative endovascular device, many features to enable off-the-shelf for the large variability of patients. It's a unique pre-procedural planning and training which improve patient selection and confidence of the operator. Initial experience is very good. No device-specific complication in midterm follow-up. Obviously, long-term follow-up is planned. And we continue to challenge the remaining challenges and to answer with a new solution for the future devices. Thank you.
Any questions? Re-intervention in 25% was that reballooning.
Was reballooning and coiling the gutters in 1B endoleaks from the distal part, where I think 3 or 4 patients where they coiled the gutters between the periscope, the parallel graft, and the descending module.
And you do not balloon the chimney?
We do not balloon the chimney. We sometimes reline it with bare metal stent inside the via band, but no ballooning, late ballooning.
Thank you very much. I'm sorry that we have to be rushed. I just want to remind you that 7 minutes and 2 minutes for discussion, otherwise it will be a big problem in the end of the session. I would like to ask Jack Sherman from Cape Town to come and present non-occlusive self-homing deployment of durable cavities in compliant aortic roots, a paradigm shift for countries with limited access to cardiac surgery. This is an extension of the nice talk we have today in the plenary from Professor Zia.
Thank you kindly for the introduction. We're going to stay on novel technologies, moving to a novel concept, this time in the field of transcatheter aortic valve implantation.